All right. Hello, and welcome to the first, possibly only, teaching invitational hosted by Emory. Kidding. Really hope this becomes annual. I am joined by my forever mic mate, always effervescent co-host, Dr. Meredith Trubitt. How are you this evening?
Doing okay. How are you?
I'm jealous you're at the beach, are you not?
Not even funny. I am not at the beach. I am sitting in the comforts of my own home.
You had quite the staycation planned after the beach fell through. But how's the staycation going? Is that actually happening?
Judgy, judgy.
I know. Okay. Before we get into too much of the competition, a brief history lesson. So, here at Emory, we've been doing a faculty teaching competition since 2017. It started as an in person event, as you can see on this wonderful picture featuring one of my dear friends. Um, and it was started to basically give people an opportunity to early in their career to have a chance to speak in front of an audience. We have this beast mode concept with 8-minute talks. And then, of course, the world spontaneously combusted in 2020. So we had to morph it into a virtual event. Um, and so we did. And we decided one of the things that had previously been true, which was people were just kind of given free reign to pick a topic, realizing that people had a lot on their plates. We made it a themed thing, so it would narrow the field. And even the first year, we assigned the topics completely. And since that first virtual competition, we've had 4 local events with increasing attendance over each year. We've hit over 100 of our faculty on this event on the call for the last probably 3 years, actually. And we've had several themes. The first one was obviously COVID, then things we do for no reason, risk stratification tools. And then again, we brought it back, things we do for no reason. And I'm sure you're wondering, that's wonderful, Moni. Thank you for all of that. But like, how did we end up here with 6 institutions across 6 states and 3 time zones? And the answer is very simple. Lenny Feldman. He was our guest judge in 2022, and he enjoyed it thoroughly and suggested maybe we needed to do this across multiple institutions. So between his initial idea and then Dan Hunt connecting me with people all across the country, this is now 2 years later. We have a reality, and I just truly cannot believe it's happening. It's a little weird, actually, to think that we managed to pull this off. So just really excited about this, and I'm so glad that so many of you are able to join from wherever that it is that you are. And for this very auspicious event, we are fortunate enough to have 6 esteemed judges. First up is Dr. Michelle Brooks. She is the Deputy Associate Chief of Staff at the San Antonio VA for Medical Education. She is a self-proclaimed Swiftie, a native Louisianan, and her favorite professional accomplishment is to tweet or not to tweet. Now, Michelle, I'm not familiar with that. That might have been my pre-involvement with Twitter and MedEd. So what's that all about?
Well, we got, so hi everyone. Thanks for having me. We got to write a paper where it was based off a workshop that we did, and they basically gave us like no word limit, which was the most fun thing that I have ever done. So me and my friends Avi and Rebecca Jaffe got to write a article for seminars in nephrology based off of a workshop we did. And it was just the best article that I feel like I've ever written. So
Awesome. And her theme song, walkout song, as I like to call them, would be Song for the Dead by Queens of the Stone Age. Next up, we have Dr. Eric Howell. He is the CEO of the Society of Hospital Medicine. He's very proud of his maritime background and says the piece of art that best represents his life is a poem written by his daughter Anna. It is called Where I Am From. And the first line is I am from humming engines and antique boats. One of these days, Eric, I am going to ask you for the rest of that poem because it sounds lovely. And he knows it's a really basic choice, but he says that his theme song would be We Are the Champions by Queen. So Dr. Lei Du Lin is joining us from George Washington University. She says her greatest professional accomplishment is completing the Master Teach Leadership Program while working full time. Meredith, this is really impressive, I would have to say.
Yeah, it is. I had to unmute. I was talking. It's fine.
And I mean, I say that because I feel like since I've been working full time, I've only really managed to get through all 8 seasons of Game of Thrones and maybe 3 pages of my adult Harry Potter coloring book. So I don't know. That's really
Teach
impressive.
their own.
I know. Some people like, for their learning and knowledge, and then other people, I don't know. I don't know what that's called. Anywho, her theme song is Happy by Pharrell Williams. Which, man, that thing would not go away when it first came out. It was like the heyday of Pharrell's production career. Yeah, man, that was like what Get Lucky came around at that time. Yeah, that was like a great run for him. All
Yeah,
right.
and then he was on The Voice.
He was. I forgot with his hats.
Mm-hmm.
And isn't he like lead designer for a major company now? Is it Louis Vuitton or
No
no?
idea.
Okay. Sidetracked. Very easy for me to do. Dr. Amit Sadani is our honorary judge for the evening. He's the chair of radiology at Emory. He is, for me, gave the most intriguing answer for the piece of art that best represents himself. He says it's Voltron. I really don't have anything to add. I just need you to explain the choice, sir.
It is a symbol of the synergy of the various academic missions.
That's even more cryptic than just saying Voltron.
I'll leave it at that.
Okay. All right. Next up is Dr. Lisa Willett. She is joining us from Birmingham, Alabama, where her most notable accomplishment is having once been my attending on Gen Med wards. Totally kidding. She is the vice chair of education at the University of Alabama, Birmingham. Her fun fact and greatest accomplishment is, and I remember hearing about this, Lisa, because it happened before I got there, but you completed 2 full marathons, and including one in which you survived a traumatic fall and still managed to place in your age group. And I remember it was very traumatic, if my memory serves.
Yeah, it was a terrible face plant, in fact, and on the very cold cement sidewalk because a root was growing up underneath it, and I lost all my teeth and posterior molars and all, not my front teeth, but my back teeth, and it was quite traumatic. So I was very proud that I got back up a year later, ran the marathon, not the next day.
But aren't you the one that told me that someone should only run a full marathon once? You did that. You did it a second time after that?
Yeah, but I was right. You should only do it once because the
Okay.
second time was terrible.
Oh, man. Okay. And last but certainly not least, Dr. Paul Williams. He's joining us from Hershey, Pennsylvania, where he is faculty for Penn State University. Before that, he was a college dropout, and unlike Kanye, he went on to become a contributing member of society, most notably in the current day as one of the original co-founders and co-hosts of the Curbsiders Internal Medicine podcast. And he says his walkout song would be Song for the Dead by Queens of the Stone Age. That's awkward, Dr. Brooks. Okay, so let's get this thing started. As I mentioned at the top, we have a theme every year. And one of the most popular things I feel like in life is things we do for no reason. Meredith, I feel like it's like, I don't know, is it like the non-GMO tag at the grocery store or something? Like you slap it on there and people are just going to buy it no matter what the content is. Like, I don't know. Is that just me?
Yeah, I guess so.
You have no idea what I'm referring to, do you?
Nope.
This is going well. Anyway, thanks to Dr. Lenny Feldman for once again letting us use his trademark. We're very grateful that we're able to use it so many times. Okay, so a little bit matters of business, the rules of engagement. So our speakers have 8-minute talks. They will be given a private 2-minute warning and a points deduction if they go over time. There's 2 minutes for questions, and just a reminder to our speakers and our judges, there are no, do not let that affect the score. So it's just for learning and discussion. It's supposed to be, that's what it's all supposed to be about. So, okay. Won't get too detailed, but I do want to make sure we go through a quick schedule of events. So first up, we've got Dr. Eileen Lee from WashU. Then we'll have Dr. Mike Jones from Emory, followed by Dr. Alex Horn at Duke, followed by Sporty Bott from Vanderbilt with our Southwestern trio, and then Southeastern trio. Then closing us out will be Dr. Hoda Farajpur Bakhtiari from Denver Health. And last but not least, Dr. Nilu Latifi representing Johns Hopkins. Okay, Let me check the chat real quick to see if I've heard. Okay. All right. And we will start off with Dr. Eileen Lee. She is representing WashU in St. Louis. She apparently loves cold Midwestern winters because she's a product of the University of Iowa Med School and residency program. She's a seasoned veteran of hospital medicine. She's about to complete her 15th year. Fun fact, she is well-versed in American Sign Language, so much so that she admits to the good kind of ugly cry at the end of the Oscar-winning film Coda. She says that her anthem would be Broken and Beautiful, performed by the greatest singer of our generation, Kelly Clarkson. And fun fact, written by other generational vocal talent, Pink. And so here is Dr. Eileen Lee to kick us off with underdressed contact precautions for MRSA and VRE.
All right, ready. So thank you, Moni, for that introduction. I really appreciate it. I'm so glad to be here. So the thing that we do for no reason that I elected to talk about was routine MRSA and VRE contact precautions. Now, I have no financial disclosures. I promise you this talk is not sponsored by the Medline Medical Supply Company, but you can't give a talk like this and not briefly touch on this doll that they legitimately used to market their products to people. Because look at her, she's like contact ISO Barbie, right? She's amazing in her little gown and bouffant cap. That's so funny to me. The funniest part I think about her is how hard they pushed to like promote their products in this copy that's on her little box. Admittedly, this sentence in the second paragraph that says, Amy feels like she could just live in these clothes, probably didn't age well in light of the pandemic. I'll give you that. But this little motto at the bottom of the screen that says comfort helps drive compliance, I think is just hilarious and just copywriting gold. It's amazing to me. The only thing they could have done to market this doll better to a person like me is give her a little I am Haldol shot as an accessory. But we'll just call that a missed opportunity. So the paper that I'm going to talk about is from 2019, and it looks at 4 different topics. Why we use routine contact precautions, the evidence that exists that they don't actually prevent the spread of MRSA and VRE, how they negatively impact patient care, and what else we can do to prevent the spread of MDROs. So that's 4 topics. We're going to cover all 4, I promise, but the clock is ticking. We got to go. So this is interactive. Really quick, please, guys, if you could grab your phones if they're handy. Zap the QR code in the corner if you're able, and tell me what percentage of your patients you think are on contact precautions. See if this works. I don't know. It may not. Ooh, okay. So the paper cites 20 to 25%. So those of you that have answered 1 and 4, you can give yourselves a pat on the back. Legitimately, 1 and 4 is a lot. 1 and 10 would be a lot, right? But the bottom line is it's a lot. So we need to look at why we're doing this again. So we're going to rewind back to 1996. Clinton has just been elected to a 2nd term in office. Michael Jordan is the basketball player everyone's talking about. Flip phones are like a brand new thing, and the CDC releases these guidelines for MDRO management. And that includes this category 1B recommendation to use contact precautions for all patients with infections or colonization with MDROs. And this is based on expert opinion, but not so much on the data. 11 years later, the VA implements the MRSA bundle, which is universal surveillance, MRSA contact precautions, and increased hand hygiene. And with these interventions over the next 3 years, they document a 62% drop of MRSA infections in their ICU and a 45% drop in outside their ICU. And everybody's feeling really, really good about this at this point, right? But fortunately, then smart people start to wonder how much of those 3 interventions are like each contributing to that success. Because science is about knowing better and doing better, right? So over the next 8 years, a bunch of papers start to come out to look at this. And this article looks at 9 of them. We don't have time to look at each individually, but as a group, there are 3 categories. So these 4 papers look at protocols where they increased the use of contact precautions. And they documented no significant change in MRSA or VRE acquisition compared to their controls. Now, there is an asterisk here because in one instance, they documented no VRE difference, but there was a small decrease in MRSA acquisition by like 2.98 acquisitions per 1,000 patient days or something. But you get the idea. There's no overwhelming evidence in favor of contact precautions here. In the second category of studies, they showed that when contact precautions were discontinued, rates of acquisition or infections with those organisms behaved exactly the same way over time as in controlled settings. And the third group is studies that replaced or compared contact precautions with other preventative measures like chlorhexidine bathing or gloving and found no difference in MDRO rates between those groups. So basically, there's a fair lot actually of evidence that either contact precautions don't add much value, or if they do a little bit, there's definitely other interventions that are equally beneficial. So while we thought the cost benefit ratio for contact precautions was pretty favorable, now it's starting to look like maybe those benefits are underwhelming. And of course, the next question is what's on the other side of that equation, right? So let's talk for a second about how contact precautions actually cause harm. So one major issue is that caring for these patients takes more time and more effort. And the natural result is that these patients have less face time with healthcare workers and they get less quality care. A lot of people will see a sign on this door and instead of stopping, pick out and glove, they just stop, like period. And that's backed up by data. So there's a study here in which the senior residents they observed were pretty good about seeing their contact precaution patients, but their attending physicians, haha, not so much, right? And this is believable to me, and I think it's believable hopefully to you too, because gowning and degowning is a burden. We've all felt this, right? And nurses feel it too. This was actually meme worthy. We've all seen a nurse do this, and maybe to her credit, she's doing it because she can't leave her patient alone safely at that moment. But we've also definitely seen nurses do this because it seems easier to them to stand in the doorway waiting forever for someone to bring them the thing they need than to tear down the gown and go get it and then come back and put a brand new gown on, right? So we've got less patient time with healthcare providers, and lo and behold, we have 2 papers that show that contact precautions are associated with significantly increased adverse events, including things like post-op respiratory failure, thrombosis, falls, medication errors, like scary stuff. No surprise then that these patients are also averaging longer length of stay compared to other patients with similar diagnosis and acuity, longer length of stay compared to what's expected for them, higher cost of care, and higher 30-day readmission rates. There's also evidence that they have more anxiety and depression, and frankly, who's to blame them at this point, right? It's because they're having more complications, more days in the hospital, fewer interactions with people, and then our interactions may feel less like this and more like that, right? They also deal with significant delays sometimes on admission and discharge. This is a screenshot from our ED track board at WashU. And I guarantee you there's always contact ISO patients on it who are waiting hours and hours longer for a bed than anyone else. So the last obvious result to talk about of all these things is that these patients have significantly decreased satisfaction with regard to their care, specifically regarding things like physician communication, staff responsiveness, facility cleanliness, and willingness to recommend your hospital to other people. So I think when we look at these costs, if we're not like completely freaking out about this at this point, at least we should be feeling probably moderately unsettled. And the question is, what should we do about all of this? So this paper recommends that we only use MRSA and VRE contact precautions if there's actually an uncontrolled outbreak or if there's uncontrolled bodily fluid exposure. But never fear, we're going to keep using it for C. diff and other MDROs, right? Don't throw the baby out with the bathwater. It also makes a really good point that instead of vertical methods of preventing MDRO spread, whereby we use surveillance to flag the bug and then just try to keep it isolated, horizontal methods of spread, where the goal is to just kill all the germs everywhere in general, work way better. And examples of this would include good old hand hygiene, chlorhexidine baths, environmental cleaning, and antibiotic stewardship. So final recs, if you have low endemic rates, hand hygiene compliance greater than 90%, which should be your goal anyway, you're probably okay to do some routine contact precautions for MRSA and VRE. We're not animals, so we're going to maintain routine surveillance to document our rates before and after and keep those horizontal prevention methods going. That's my 4 objectives in 8 minutes. If you want to read the paper yourself, we've got a QR code where you can go to PubMed and read it. But thank you very much to the organizers of this event and my WashU family for their support.
Awesome. Thank you so much, Eileen. That was awesome. Like I said at the top, if you have any questions for Eileen or just for discussion points, just drop them in the chat. And if you wouldn't mind, please tell us where you're from while you're at it.
You mean in the chat for everyone?
Yeah, not what did I say?
You just said in the meantime. I just want to make sure not everyone got on mic.
Oh, correct. Sorry. Yes. Please keep it to the chat box.
That was a really great talk and I love the animations.
Oh, thank you.
So no questions yet, but a couple of comments. So just terrific presentations. And so first question, Mark Williams, how do we get hospitals to change their practice?
Mark, you're asking me how do we get hospitals to change their practice? I mean, I think we've we've got to present this data, right, to the powers that be, which is above my pay grade, but I have supportive and wonderful bosses and people ahead of me that can do this sort of thing and try to affect change. But I think, you know, when we talk about change management, you've got to figure out what's important to the people at the top and go for that, right? And point out how what you care about is relevant to them. So that's the best answer I got.
And then there's a couple questions also on cost. If you have any information on like cost of like the yellow gowns or cost of any of like the contact precaution equipment.
So everybody asked about cost for yellow gowns. I actually do not know legitimately what our hospital pays for yellow gowns. I will say that I tried to dig up on the internet when I was doing this, and you can get like big packs of gowns on Amazon for less than like 60 cents a gown. So I was talking to a medical student who was convinced that the gowns were costing like 10 bucks a pop. And I'm like, I hope we're not paying 10 bucks a pop for these gowns. But I think the increased cost of care that we're talking about has less to do with the cost of the gowns and the actual equipment, and more so the cost of care regarding, you know, these like increased lengths of stay and like other complications.
Yeah, Michelle said the urban legend is that they're like $5 a gallon. That's the number I've always heard. And Paul said, I'm sure we charge $37 a piece. I agree. I think that probably what gets put on the invoice is different than what the cost to make the gown is.
But I feel like the cost is like they would listen to that. Like if we were able to illustrate how much money we're spending on something that may not be necessary. I feel like people listen to the Benjamins all the time.
Yeah. Although I feel, I mean, the VA, I feel like everyone gets a contact precaution for existing. Yeah, and a couple of comments just also to cost kind of on the climate effect going into landfills and like downstream costs of that as well, which I think is a great point. And I haven't seen any other specific questions. So I'm guessing we're probably getting close to the 2 minutes anyway.
Yep. Think so.
Cool.
All right. So next up we have Dr. Mike Jones. He is the hometown fave. I mean, we can't be a Homer cast Meredith, but I'm always tempted, as you know. Mike was born in the UK and then immediately downgraded to living in Jersey. Sorry, the Jersey jokes are way too easy, Mike. It's going to happen all the time. He's a member of the newest crop of our hospitalists here at Emory. Interestingly, he's basically like cycling Forrest Gump. He's cycled cross country twice, once in 2013 and then again in 2015. His theme song has changed since our local event. It was Help by the Beatles initially, and now it's Life is a Highway. He credits this to the Rascal Flatts. However, for the music nerds out there, you will know that it was actually originally by Canadian singer Tom Cochrane and was released in 1991. Anyway, that's just me probably. Now here he is with his talk, To Stress or Not to Stress.
Thank you so much. I don't know how to follow up the those facts. All right. Well, welcome to my talk titled To Stress or Not to Stress. Today we'll be discussing a thing we do for no reason. That is ordering functional stress testing over coronary CTA in the evaluation of intermediate risk chest pain. We've all done it. On the agenda, we'll talk about limitations of stress testing, benefits of coronary CTA, and based on that, my recommendations. So jumping right in, limitations of stress testing. And what I hope to highlight is that when using stress tests for their designed purpose, obstructive disease, their performance may not actually be that good. And more importantly, when you look at non-obstructive disease, they're probably missing this diagnosis. So to highlight that first point, this table looks at the relative sensitivities, specificities across all the various stress modalities. And if we look at stress testing with imaging, we see that the pooled sensitivity is about 80 to 90%, pooled specificity about 70 to 80%. So that means there's about a 20% false positive, false negative rate with these tests, 1 in 5 patients. And if we turn our attention to non-obstructive disease, we know that stress tests are designed to look for flow limiting stenosis. So by definition, they are probably missing non-obstructive disease, which is not flow limiting. And I think that's a big problem because there's good data to show 2/3 of future MI are probably coming from non-obstructive disease. And I think this table does a really great job of highlighting that point. So this is the annual rate of death or MI following a normal and abnormal stress test. And if we look at the annual rate following a normal stress test, across all the modalities, it's about 1%. And initially I thought, oh, wow, like that's not that bad. But there's 10 million people getting stress tests each year. 70% of those stress tests are read as normal. And so 70,000 patients each year are having MI or cardiac death after a normal stress test. And I think that's probably because we're missing non-obstructive disease. And so it might make you wonder, is there a better way? And I think coronary CTA might be that better way. And all it is a CT with IV contrast having a dedicated look at the coronaries. As an aside, it is not calcium scoring. That's a separate test, separate purpose. But for CTA, I hope to show you that for obstructive disease, it performs better. For non-obstructive disease, there's a trend to better performance. And there's good data that using coronary CTA actually changes management and does improve outcomes. So for obstructive disease, coronary CTA has a pooled sensitivity about 98 to 99%, specificity 82 to 89%. And if we compare that to stress testing with imaging, which we looked at earlier, we see indeed it is better. And there's a trend as well to better diagnosis of non-obstructive disease. And to highlight that, I'd like to run through the PROMISE trial. So the PROMISE trial was a multi-center RCT. It looked at about 10,000 patients with intermediate risk chest pain, randomized them to stress testing versus coronary CTA with a composite endpoint, including death, MI, and a few other things listed here. And this is a table of data from the PROMISE trial that highlights some of the data that I found most interesting. It's basically the frequency of test findings over here on the left and the corresponding event rates as they relate to that composite endpoint. The left side here is CTA, right side is stress testing. And if we look at coronary CTA, we see it was able to identify about 55% of patients as mildly abnormal, AKA non-obstructive disease. The rest, 33%, were normal. Stress testing, on the other hand, hardly anyone is non-obstructive disease, less than 10% of patients, while almost everyone, close to 80%, are normal. And to see why that's important, I think it's helpful to look at the event rates. So CTA over here on the left, we see it's picking up a meaningful difference, 3% versus less than 1%, by identifying people as mildly abnormal. Stress testing over here on the right, can't really tell the difference, 2% and 2%. And I think that comes down to CTA's better ability to detect non-obstructive disease. And just to hammer home why I think this is so important, the Scott Hart trial is another really helpful trial to look at. So this was a prospective RCT, looked at about 4,000 patients throughout Scotland, randomized them to standard care or standard care and CTA, and a primary endpoint of death or non-fatal MI. And this trial found a number of things, but essentially CTA with standard care lowers the rate of composite endpoint at 5 years. And it was statistically significant, which we all love. And follow-up analysis showed it was due to primarily lowering the rate of non-fatal MI, probably because CTA was picking up more non-obstructive disease. And as a result, more patients got started on preventative therapies, 20% just about in the CTA group versus less than 15% in the standard care. And so big takeaways for me regarding coronary CTA, it has a higher sensitivity and specificity for obstructive disease. There's a trend to better diagnosis of non-obstructive disease, shout out to the PROMISE trial. And using CTA leads to better long-term outcomes by getting more people on preventative therapies and having less rates of coronary heart disease death and non-fatal MI. And all of this data was so convincing that in the UK, my home country, CTA is actually the first line test for intermediate risk chest pain. The United States hasn't quite caught up with that, but as of 2021, the AHA ACC does recommend either CTA or stress testing in the work of intermediate risk chest pain. Prior to 2021, it was just stress testing. So I think we should be doing more CTA. There are, of course, some limitations, though. Tachyarrhythmias, elevated BMI, and age over 65, all of these are going to limit our image quality. And if you're a believer in contrast and renal dysfunction, that, of course, is going to be a limitation as well. So all of this taken together, what are my recommendations? If you have a patient with intermediate risk chest pain and none of these limitations over here on the left apply, go ahead and order the coronary CTA. You'll end up not missing non-obstructive disease. You'll start more people on preventative therapies, and you'll improve 5-year outcomes for your patients. And that concludes my talk. These here are my references, if they pop up, there we go. And I'll leave up the visual abstract for your viewing pleasure and take any questions that might be out there.
Thanks, Mike. That was awesome.
Yeah, nice job, Mike. Yeah, so if you have any questions, put them in the chat. I think we're about to see the, yeah, all the Emory, great job.
The warm hug, it's back. I always talk about our chat during our local competition being just a big warm hug. And it's back. Super pumped.
Yeah. Okay.
Blown up.
Sorry. Oh man. People are typing too fast. Okay, performance of coronary CTA will only increase as newer generation photon counting CT scanners are adopted, providing faster imaging, better resolution, and the ability to see through stents, which is the benefit of having our radiology colleagues here as a judge.
Yeah, I was going to say that's a little above my pay grade, but that sounds like a very, yeah, I agree.
Lots of great presentations. Manpreet says, warm hug, Mike. Paul wants to know, great talk. Do you know if there are any data regarding whether these patients were already on appropriate therapies? I would suspect if you're intermediate risk, you deserve a statin anyway. But
yeah, I think for at least the Scott Hart trial, all the patients that were enrolled were not on any preventative therapies, and the CTA and versus standard care was kind of how people ended up on preventative therapies. And people in the CTA group had just more, there is a higher prevalence of people ending up on those.
awesome. Michelle says, from Lenny, biggest problem is availability of the CTA in the community.
Totally. Yeah, I think with any imaging study or test, it's obviously going to depend on your center, if you have radiologists who are trained to read it, if it's cost effective at your center. So I think we probably all have the luxury of being at very big centers, and this is probably very applicable to us, but that might not be the case out in the community for sure.
Yeah, I think the working hours for us are like 8 to 3 at the VA. Is that right? Or 8 to 2, something like that. So limited window to get them done, but great study.
Okay, that's time.
Great. All right. Next up, we have Dr. Alex Horn. She is representing Duke. She is a native Texan and actually Dallas specifically. And she's at Duke now by way of Hopkins for residency. So we have a little bit of Hopkins representation multiple ways today. She is a hospitalist now of 3 years and says that she wasn't a doctor. She would be a travel blogger. Alex, where is your favorite place to go? What's the best travel you've done?
Oh man, I think one of my favorite places, my husband and I just went to New Zealand a few months ago and just had an amazing time hiking and just experiencing the beautiful outdoors there.
Yeah, I got your fun pictures and I have something for that at the end, so don't worry, they're coming. The kayaking was awesome. So both her theme song and piece of art that best represents her life is the chorus to Avicii's Nights. Tell me about that.
And just, it's a song that really just talks about sort of living life to the fullest and that we all really aren't promised tomorrow. So something I just like to remind myself sort of day to day.
Gotcha. R.I.P. Avicii. And now here she is with her talk, Pearls and Pitfalls of Correcting Calcium for Albumin.
Great. Well, thank you all so much for having me today. I'm so excited to be here. I see many faces in the audience, people that I love and respect, both from Duke and the Durham VA, as well as from Hopkins, my residency alma mater. So it's great to see all of you. Today, I'm very excited to talk about an article that really changed my clinical practice, and it really changed how I teach students and residents, and that's calculating a corrected calcium for low albumin. First, I really want to paint a picture for you. So I want you to imagine that you are the attending on Gen Med this week, and you are on teaching service. You have a very excited third-year medical student who's presenting a case of a 72-year-old male who's coming into Gen Med with a right lower extremity suppurative cellulitis. Their comorbidity burden is notable for gastric adenocarcinoma. They've had chemo and radiation. They've also have CKD stage 3B with a baseline creatinine of 2.2, as well as HFpEF with grade 2 diastolic dysfunction. As that student presents the CMP, you hear that there's a low albumin of 1.5 and a total calcium of 9.9. So you very excitedly are planning the teaching, and you are going to teach the student about calcium correction. But before you do so, I really want you to pause and say, what is this data based on? Should we actually be doing this in 2024? And so I hope over the next 7 minutes or so, I can look at this data with you under a microscope and in the process debunk this common practice of correcting calcium for serum albumin. Along the journey to get there, we're also going to review and outline the distribution of calcium in the body. We'll talk about some of the physiologic consequences of extremes of calcium. We'll also understand some of our lab limitations and how we measure calcium. And we're going to explain the theory behind the correction equation and why that theory has not actually borne out over the years. And so just an overview, how is calcium distributed in our bodies? And as a reminder, 99% of calcium is bound to phosphate in our skeleton. It's the most abundant mineral. The other, just very small 1% is non-skeletal. And the combined components of this is what we get on a CMP when we look at a serum calcium, a total calcium. And so that's going to be a combination of your bound components. Primarily, that's bound to albumin, as well as ionized. So about 50% is ionized or free. And a very small 10% is also bound, but bound to lactate and citrate rather than albumin. And as a reminder, it's the ionized calcium, right? This free calcium that is what's biologically active. And so even though on our complete metabolic panels, we're measuring the combined total components of the bound and non-bound, it's really the iCal that's biologically active and is going to give us symptoms at extremes. What are those symptoms? Of course, as you guys know, for hypercalcemia, we see our bones, stones, groans, psychiatric overtones, right? So our symptoms of hypercalcemia in terms of treatment, we're going to give people heavy amounts of normal saline, often calcitonin in the short term and bisphosphonates. For hypocalcemia, we can see a lot of neuromuscular irritability, so paresthesias, Trousseau signs, seizures. We can even see arrhythmias and prolonged QT, with treatment, of course, focusing on supplementing calcium either IV or orally, often vitamin D, and ensuring that other electrolytes are repleted. And so where does this correction equation come from? And so again, we've established now that our total serum calcium is what we look at on a complete metabolic panel. And we know that that's a combined component of bound and ionized, but it's the ionized component only that is really going to drive the physiologic effects of calcium. And so why don't we just get an iCal in everyone? The challenge with that is that ionized calcium can just be very hard for labs to obtain an accurate value. And that's because it's very much impacted by things like pH and temperature. So it has to be run very quickly, stored at certain temperatures to have accurate measurements. And so that's why routinely we will look at the complete metabolic panel. And so when we looked at pain studies for correction back in the 70s, his theory was that, okay, we're looking at bound and ionized. If our albumin goes down, our serum albumin, our bound component is going to go down, but our ionized is going to remain stable. So again, our total calcium will go down because that bound is down, but iCal stayed stable. And so do we now need to correct the total calcium to reflect this stable ionized calcium at low albumin levels? And again, so this is Payne's equation from very small studies in the 1970s that assumes a linear relationship. So what you see here is that as serum albumin goes down, total calcium goes down, but across serum albumin, iCal is staying the same. And this is what led to the most famous calcium correction equation that many of you have used and may still use today. I certainly did until I read this article. So back to our patient, right? Our patient with underlying malignancy, HFpEF, CKD with an albumin of 1.5. If we plug his data into Payne's correction equation, we would end up getting a corrected calcium of 11.9. And as you can imagine, that may end up triggering some hypercalcemia therapies, particularly IV fluids, maybe even calcitonin and bisphosphonates. But should we be doing that? And so I would argue that with the data we have now, to not use the calcium correction equation. And what is the problem here? So again, this is what Payne postulated from the 1970s, is that there is a linear relationship, saying that when albumin goes down, calcium bound to albumin also reduces. But what many, many much larger studies have shown since the 1970s is that this equation really does not predict well ionized calcium. And that is because, especially at extremely low albumin levels, the binding capacity of albumin for calcium actually increases. And so the reality really of these severely low albumin states, as you see here, is that when that albumin goes very low, that binding capacity actually increases. And therefore, there's really minimal change in total calcium with low albumin. And so what are our take-home points here? Calcium correction for low albumin states does not correlate well with ionized calcium levels, and that's in many, many large studies since the 1970s. And this is particularly inaccurate with severe hypoalbuminemia. Correction equations then will lead to an overestimation of total calcium. And as you can imagine, a lot of iatrogenic harm from overtreatment, right? Who are these patients in the hospital setting who have very low albumin, right? It's patients with malignancy, patients who are malnourished, those that have cirrhosis or chronic kidney disease, and are going to have a lot of harm from heavy amounts of IV fluids that are not needed. And this just sort of looking back at our patient here and what his comorbidities were. And so what should you do instead? So again, do not use the calcium correction equation. I would take it out of your clinical practice and your teaching. Instead, you should use an uncorrected total calcium from your CMP for just routine monitoring for calcium homeostasis. And if a more accurate measurement of calcium is really going to change your management, then that's where you want to obtain a direct iCal instead. And I hope this was helpful for everyone. Thank you so much for having me.
Awesome. Thank you so much, Alex. I'm really pumped that I don't have to do calculations myself anymore. Very exciting.
Because you would do the calculations yourself.
Obviously.
And whip out that pen and paper.
Math is not my forte, as you're aware.
So lots of go Dukes in the chat and everything. MD Calc will be sad. That's a good comment. All right. Man, Monica is on top of it. All of you guys just had seconds to spare. Any questions?
Just warm hugs. I'm so glad everyone's contributing to the hugs. Just think about all the times that I ordered an iCal and then gave calcium, and maybe I didn't need to be doing it the whole time.
Yeah, I'm just thinking about how many minutes during residency were you calculating corrected calciums? And how many minutes could you have been sleeping then?
Not enough minutes is what my attendings would tell me.
Just me. Okay. Eric wants to know, when is it worth really doing an iCal, if ever?
I think, so all the data has shown that what correlates best with ionized calcium, rather than any correction equation, is actually just our total serum calcium from a CMP. I think if you are particularly at really extremes of albumin, and maybe you have a borderline calcium where it's going to, if you feel like it's going to change your management, you could consider getting an ionized calcium, but really only in those situations.
Oh man, Alex, you're on top of the chat too. All right, awesome. If anyone has any other questions, now would be the time. Otherwise, we can probably move to the next.
We shall. Dr. Spurthy Butt is representing Vanderbilt. She is a vagabond in the truest sense of the word. She immigrated to the United States when she was 2 years old and has lived in basically every time zone. She went to med school at Tufts and then completed residency at Vanderbilt and is now nearing the end of her first year of attending life. She's an avid traveler. In fact, she's probably still a little bit recovery mode. She just got back from the Galapagos 2 days ago. MT, that sounds rough to have just gotten back.
I went straight back into geriatrics, and I'm actually like losing my voice. And of course, because it's Jerry, I'm talking very loudly and trying to make sure my deaf patients can hear me. So a little struggling today, but that's okay.
Yeah. And this was really cool, Shpurti. So you said that the art that best represents you is actually art you do yourself. So art takes a lot of forms. What art do you make?
When I was in undergrad and I had good access to a big studio, I did a lot of oil painting and figure drawing because we had nude models. We would do a lot of that, and it gave you a lot of appreciation for human anatomy. Now I mostly do acrylic just because it's easier to clean up and it's easier to do in my own home when I'm wanting to de-stress. And it's probably the best way that I handle, coming back from a long day or a long stretch of inpatient and just wanting to do other things to take my mind off of medicine.
Yeah, smear a bunch of red against some canvas. That sounds glorious.
Yeah.
And her current anthem is "You Can't Stop This Girl" by BB Rexa. And BB Rexa, Dua Lipa, Rita Ora, they're all just like crushing it. I think they're all, is it Bulgarian? I think they're all Bulgarian, something. Anywho, not important. Here is Dr. Bott with inpatient glucose management.
My main goals and objectives of this talk is to review the classic teaching, things that we've been taught as indications for reasons to hold metformin in the hospital, and really understanding the historical reasons for that, and kind of updated guidelines that we have now based on newer data that we received, and guidelines from professional societies that have really said that maybe the reason that we're holding metformin doesn't really quite make sense, and we shouldn't be doing that in the hospital anymore for all comers. So I want to start off with a basic teaching case. And so the clinical scenario is just a 27-year-old male that's otherwise relatively healthy, has type 2 diabetes and class 2 obesity, coming in with some simple cellulitis after failing outpatient antibiotics, and is admitted for a day or two of IV. As you can see here, really not super contributory history other than maybe a social drinker, really only takes metformin and PRN hydroxyzine at home for anxiety. Based on his exam, really just simple cellulitis, no evidence of sepsis, and his lab work is grossly unremarkable other than a slightly elevated glucose to 206 for inpatient. And his A1C, you can see, is not well controlled outpatient, but nothing egregious like the 13, 14s that we've seen in inpatient setting. So my quick question to all of y'all would be, what medications would you order for this patient other than PRNs? Just take like 1 or 2 seconds if anyone wants to unmute and chime in what they would order for them. All right, I'll move on. So really quick, I just want to look at some basic pathophysiology. I promise I'm not going to belabor gluconeogenesis and that whole cycle that we had to learn for step 1. But the big things I want to highlight here is the main mechanism of action of metformin. The primary mechanism is that it downregulates our gluconeogenesis, and it also downregulates the absorption of glucose from the GI tract. And then it also upregulates the actual peripheral conversion of glucose into active products and metabolism in our peripheral tissues. Conversely, insulin, particularly the sliding scale insulin that most of us use in the hospital, is really only working at upregulating the absorption of glucose from the bloodstream into the tissues. When you're only using short-acting insulin, that's your primary modality there. So the main reason we've all been taught that we need to hold metformin in the hospital is because of this big metformin-associated lactic acidosis, or MALA. And it's really because there's been thought that there's shunting of metabolism to the anaerobic pathway with increased lactic acidosis, and that since metformin is primarily excreted in the kidneys and frequently our admitted patients are at risk for AKI or disease states that cause AKI, then there's going to be a risk of lactic acidosis in patient. Additionally, many of our patients receive IV contrast, and there's been a classic teaching that that is associated with increased risk of lactic acidosis as well. When metformin was initially released to the market, there were 47 reports of non-fatal metformin-induced lactic acidosis, but notably, all of these were in CHF, AKI, hypoxia, or sepsis, other disease states that we know are likely to cause lactic acidosis. And actually, this initially led the FDA to say that CHF was an absolute contraindication for patients to be prescribed metformin, even in the outpatient setting, which, as we all know, has since then been removed. So really, the reason for a lot of this bad rap is from fenformin, which is metformin's nefarious older sibling that caused more problems. So this medication came out to the market many years prior to metformin, and actually soon after it was released, there were over 300 cases of fenformin-induced associated lactic acidosis, which caused it to be removed from the market. And studies had shown that it actually did upregulate more of the anaerobic metabolism that led to shunting towards the pathway that created more lactic acid. And since then, we've had many, based on that initial data, the Endocrine Society, as well as the American Diabetes Association, had recommended that all comers that get admitted to the hospital have metformin held, especially if they're at any disease states that could put them at risk for an AKI. Since then, we've had many, many studies that have showed that this is probably not really necessary, particularly here. These are all the studies that are listed in the main article on Society of Hospital Medicine, but the main study I wanted to highlight was Salpeter et al., which is some of the best data out of all these studies, which is a systemic review that showed that there really is not a difference in the risk of developing lactic acidosis between patients on metformin or other agents. And it's actually led to the Endocrine Society changing their recommendation for holding metformin on inpatients to weak with very low quality of evidence. So going back to this, there's actually been, back to our pathophysiology slide, there's been some more updated data that has shown that, admittedly it's in surgical patients, but has shown that all of these other ways that metformin kind of helps with our glucose metabolism, glucose regulation, we really don't get with sliding scale insulin, as is noted here, because there's really only one mechanism or site of action. Because of this, we're actually seeing that patients who are getting sliding scale insulin alone tend to have more hypoglycemic effects, tend to also have more hyperglycemic effects, and tend to have longer length of stay compared to metformin use. And this has actually led the American Diabetes Association to change their recommendations and to say that we should really re-prescribe inpatient, put the patients back on metformin within 1 to 2 days of discharge as they're getting more medically stable. So when should you actually hold metformin? Patients that are at high risk for conditions that are likely to cause lactic acidosis for other reasons, so as not to cause any confounding in the situation. But so typically, high risk for severe sepsis, hypoxia, COVID is a big example of this because frequently our patients had all of the above here. But really, this take-home point here is that if you're having stable patients that are being admitted to the hospital, maybe just for OBS, like our young male that was coming in for 1 day of IV antibiotics, it is probably reasonable to just continue their metformin, and it'll actually reduce their length of stay and probably have better glucose control while they're there in the hospital. And that is all I have. So questions?
Awesome. Thanks, Bertie. Any questions, drop them in the chat. So I did not know about the older sibling, fenformin. Oh, Meredith, you're back. Sweet.
Yeah. Sorry, I'm just off camera. All right, lots of great talks, great jobs. Great topic. Any questions?
Tough crowd, man. They're just learning so much. I think we're just blowing minds left and right.
I know.
That's just the level of talks we're getting, man. Just
Oh man, moments to spare.
great.
Want to just give it like. All right, Dan has a question. Great talk. How do you convince pharmacists that it's okay to continue?
I've actually had pretty good luck with this. I've kind of just talked to our pharmacist and patient, especially when the patient's admitted OBS, and then like, listen, like, are we really going to change a lot of their outpatient management when the reason for their admission has nothing to do with their diabetes? And this is probably reasonable to just continue the environment that they would have if they were at home. I think what's really helped also is like the whole push for hospital at home to really mimic like some of these patients, showing like what are they going to do on their own when they leave the hospital. Let's try to mimic that environment. And it's probably the best way to be able to have adequate glucose control for them and the ways that they're going to reproduce when they go home.
Yeah, I think that's true.
I feel like that's always the question. Like, how do you work with pharmacists? How do you work with consultants when it's a consultant related thing? Like, we have this data, but is it really just our revenge on all these other people?
And then another Dan would like to know, how do you convince radiologists to let CT scans happen on metformin? We do have a radiologist on the call. That could be a longer conversation though.
We stopped asking about metformin several years ago. We don't ask, we don't check, we don't care.
I was going to say, I don't think I've been asked because I think there's been, to your point, there's been plenty of data that has shown that it doesn't really matter. And there's not actually an increased risk of lactic acidosis with contrast administration. If your patient has other reasons to have concern about contrast administration, then address those. But metformin in isolation doesn't really make sense.
And Manpreet's going to try it on his next stretch with his pharmacy team.
Let us know how it goes.
Please.
Awesome. All right. Time is up for questions, so I think we can go to the next.
Great. Next up, we have Dr. Hoda Farajpur Bakhtiari. She is representing Denver Health and the University of Colorado. She is originally from Iran, where she completed medical school in Tehran and then residency at the University of Colorado in Denver. Man, that's quite the hike. That's impressive. Very different weather, I'd imagine. This is her second year from out of training, and her fun fact just like was, I know I keep saying warm hung, but it really was. Her great aunt thought that her name was it Khadija or Khadija? Until the day that she died. And her great aunt had suggested this name to Hoda's parents. And like any good set of parents, they didn't really want to break this great aunt's heart. And so anytime she was visiting, they would call Hoda Khadija so that she wouldn't find out. And they did this until her great aunt had died. So that is like such a sweet story. Yeah. Thank you for sharing that. Yeah.
And then just going back to your first, actually Iran, Tehran and Denver have the same altitude. So yeah, that's not a whole lot of change in climate.
This is why my grade in world geography was terrible. Anyway, your anthem is Send Me an Angel by Scorpions. I gotta say, the music taste in this group is fantastic, just so eclectic. And here Hoda is with her talk, Colonoscopy Prep. Which prep is it anyway?
All right, so our topic for today is colonoscopy. Which prep is it anyway? Or maybe we should say whose prep, but we'll get to that. I have no disclosures. So for today, we're going to review standard bowel preparations for routine colonoscopy. We're going to compare high volume and low volume preps for colonoscopy, and also just go through the recent data on efficacy outcomes and patients' tolerance. Why is a good bowel prep important? We know that it has quite an effect on quality of our colonoscopy. It impacts our diagnostic accuracy, polyp detection rate or PDR, and adenoma detection rate or ADR. It affects procedural duration and all the risks that could be associated with that prolonged procedure duration, and all the other adverse events associated with colonoscopy. If a patient needs to repeat the colonoscopy just because of poor prep, it can add to overall costs, it can increase wait times, and the entire experience of doing the bowel prep can affect patients' willingness to repeat the procedure. What preps do we have available? These are formulations currently recommended by ACG. Our standard, good old Go Lightly. It's polyethylene glycol, which is an osmotic laxative, paired with some electrolytes. Volume is about is a gallon, so about a liter, 4 liters. And then we also have some low volume preparations. Some are peg based, movie prep, half likely, or some of the brand names, the volume has been decreased to 2 liters. And then a more concentrated one, even less than the other two, is PEG ASC, which is PEG plus ascorbate, and that volume is down to 1 liter. We also have some non-pig based, which are less commonly used because of some precautions and side effects. Osmo Prep is in tablet form. It's just essentially a phosphate-based prep, 30 tablets that patients take with about 2 quarts of water, and Fleet Phosphosoda, also phosphate-based. Patients take that with 2 to 3 quarts of water or Gatorade. So we have all of those, but why do high volume preps make sense? Because they do. And then when you look at the evidence and the history, before Go Lightly, gold standard was 48 hours of liquid diet, clear liquid diet, and then 240 mils of mag citrate and an X-Prep Senate derivative. And I don't know about you, but personally, I don't want to take a medication that has X in it. So yes, compared to that study coming from 1985, with only 24 liters of some fluid, makes sense. And we do have a lot of data to support that. So just one systematic review, this is looking at 4 liters split dose, which is now the usual recommendation. It shows that it's superior to other bowel preparations. But this study is a little bit older, it's like from 2012. There were some studies also from like 2015, 2016, even looking at tolerability and compliance, and still showed that maybe Go Lightly is still better. But there are some challenges to high volume prep. It's a lot of fluid. 4 liters of fluid, just drinking it within a short span of time is physically difficult. It can cause nausea and vomiting and add to the fluid loss and dehydration that our patients may experience just going through the prep process. And then all of that experience, again, can affect our patients' compliance and willingness to do this again, whether it is immediately or within 3 years, 5 years, 7 years, 10 years, depending on what they find. So what does our recent evidence show? We talked about some older evidence from like 2015, 2016 and older. So this is a large systematic review and meta-analysis from 2020. They looked at 17 randomized trials comparing low volume split dose regimens, both PEG and non-PEG based, versus high volume, which is our Go Lightly. And it showed that the low volume regimens were better tolerated and had superior compliance, and they were non-inferior when it came to effectiveness. So this forest plot is looking at the primary outcome, which was rate of adequate bowel preparation in the overall colon. And as you can see, the difference was not clinically significant when they put all those trials together. This is another one from China. This is another big systematic review and meta-analysis. And then when they compared the high and low volume pig-based regimens specifically, this first plot is gut cleanliness based on Boston Bowel Preparation Scale and Ottawa Bowel Preparation Scale. So different scoring systems, no clinically or statistically significant difference between the two regimens. Again, the second one is pass rate. So qualified bowel cleaning pass rate between high and low PEG-based regimens. No difference between these groups. And this one is the interesting one that is looking at patients' willingness to repeat this regimen. And as you can see, the low volume group had a higher chance of or lower risk of not wanting to repeat this. So that one is statistically significant. So we talked about routine colonoscopy, but how about high-risk patients? Or IBD patients are a group that comes to mind when it comes to colorectal cancer screening. This trial is not a big one, but it is looking at one-to-one comparison between high PEG-based regimen, so go lightly, low PEG-based regimen, which is that PEG ASC that I talked about before, and a sodium picosulfate based regimen. And it showed that, again, even in this population, the high volume or the low volume PrEPs are non-inferior to high volume PrEPs, and patients tolerated better, accepted better. So, in conclusion, I think maybe we are getting to a point that high volume PrEPs are a thing of the past. Low volume PEG and non-PEG based bowel PrEPs seem to be as effective and more tolerated when we compare them to high volume bowel PrEPs for routine colonoscopy. And I will end that with this cheesy dad joke. Why did the colonoscopy PrEP get invited to all big parties? Because it knows how to clean up before a big event. And questions?
Thanks, Hoda. We got to steal that one for curbsiders. That was a good one.
Yeah, I was going to say Matt's not on here.
Oh man, Paul, how do you feel about that one?
He's taking notes.
I think Paul should use it on Matt for their next GI episode.
Yeah, I think it'd blow Matt's mind that Paul had one.
First question, do you guys have the low volume PrEPs on your inpatient formulary?
Not to my knowledge, at least not at Denver Health. And I can imagine that, especially Denver Health being a safety net hospital, cost is always a barrier. And I can imagine that all of these novel, highly concentrated regimens are more expensive. So I think at least at our institution, we're going to stick to the standard of care for now.
Lots of great talks, interesting topics. Leigh wants to know any data on how affected the Cosmo PrEP tablet is compared to Go Lightly.
I think I found one. I can't remember if it was the tablet specifically or not, but it did compare Go Lightly to the phosphate-based PrEPs. Again, non-inferior. I would add that the phosphate-based PrEPs are apparently not even commonly used in Europe, so data is a little bit limited. And also, at least as a hospitalist, a lot of my patients, I may not use a phosphate-based PrEP for them because of the nephropathy risk and we can't use them in CKD and ESRD patients.
Well punned, Manpreet. I feel prepped to this in a few years.
Yeah, clinging to that last age, like last year of life before whatever age was it, 45? It's gonna go well next time I see him in person.
All righty. I don't see any other questions popping up, so
yeah.
Sweet.
Great job.
Right. Our last, but certainly not least speaker is Dr. Nilu Latifi. She is representing Johns Hopkins. She trained at Beth Israel Deaconess Medical Center in Boston and is current faculty at Johns Hopkins School of Medicine. Fun fact, she got to play and feed elephants in Thailand last year for an entire day. Important question. How did this happen and how do I get to do this myself?
Oh my God, everybody, I recommend going to Chiang Mai. And they have lots of places where you literally spend a day walking around with elephants in the jungle and just feeding them and playing with them. It's lovely.
Yeah, what did you feed them? Anything more than peanuts? I feel like that's
all it was
in America.
No, they literally give you like these specific feeds that look kind of gross, but they really enjoy it. And then you have to say bun bun, and then that makes them open their mouth, and then you just feed it to them.
Sweet. And playing with them, did you get to sit on them or was it just like around them, just like waving?
Sitting them is on the unethical side. So you just they're like frolicking about and you're going about with them and like putting water on them. You can swim with them.
Awesome. That's really cool. And we have a few travelers presenting today, so I think you should all swap stories after we're done. Okay, your walkout song is "Fight Song" by Rachel Platten. I would call that a new classic. Here is Neela with "Breaking the Echo Chamber," value-based syncope evaluation.
Okay, well, thank you everybody for staying back for the final talk. I'm Neela Latifi. I'm excited to talk to you about breaking the echo chamber, value-based syncope evaluation. So by the end of this talk, I'm hoping that you'll be able to describe the indications for ordering an echocardiogram and evaluating syncope, and also to create a teaching script using an evidence-based approach for ordering echocardiograms and syncope evaluation. So let's get started with our first case. We have a 64-year-old woman with hypertension, hyperlipidemia, and diabetes who's presenting with witness syncope. She was standing in line to vote prior to the episode, and her prodromal symptoms included peripheral vision darkening and flushing, but she had no chest pain or palpitations. Her exam is notable for normal vital signs and negative orthostatic vitals. And you can see that the cardiovascular, pulmonary, and neurological exams are all within normal limits. And she has an EKG that shows first-degree AV block. So as we're going forward in this talk, I want you to think about these two questions. What is the likely etiology of this patient's syncope? And would you order an echo for her? So let's think about what the guidelines say we should do for evaluation of syncope. So the 2017 ACC guidelines recommend that every single patient who is being evaluated for syncope has three things done. There's an incredibly thorough history, an exam including orthostatic vitals, as well as an EKG, and additional evaluation is only indicated if any of the above is abnormal. So let's start off talking about history. So there are historical features that increase the probability of cardiac syncope. These would be high-risk prodromal symptoms, including chest pain or palpitations, as well as a lack of any prodrome prior to the event. In terms of presyncopal activities, our concerning would be exertional syncope or syncope at rest or in a supine position. And the comorbidities of concern would be known structural or ischemic heart disease. Now, if we think about historical features that decrease the probability of cardiac syncope, we're familiar with prodromal symptoms of nausea, vomiting, sensation of flushing or warmth, lightheadedness prior to the event. The presyncopal activities are changes in position or syncope that has specific triggers like micturition or defecation. And for comorbidities, this would be a patient without known cardiac disease. Now, when we turn to the exam, in addition to the orthostatic vital signs, you want to listen to the heart for arrhythmias and murmurs and focus the rest of the exam on assessment of signs of heart failure, such as volume overload. And lastly, for the bucket of EKG, we think about two separate ways that we assess the EKG. One is assessing for signs of new or old ischemia. And the second side is looking for electrical issues. This would be sinus bradycardia, sinus pause, second or third degree AV block. And I'll note here that first degree AV block is a freebie and it's not considered an EKG abnormality when it comes to this space. We're also looking for fascicular blocks, QTC prolongation, PAC, PVC, or things like Brugada pattern. So when we take all of that and we apply it for our patient case here, we see that based on her history, based on the exam and the EKG finding, she really does not require any additional workup for her diagnosis at this point. But you are on a teaching service and you have a very eager intern on your team who notes that the patient has multiple risk factors for cardiac disease and wants to order an echo just to be sure. Now, given the high morbidity and mortality risk of cardiac syncope, we often worry about missing this as an etiology, and that can lead to automatically getting an echo for every patient presenting with syncope. And I hope that I can show you that one of the things we do for no reason is routinely ordering an echo for patients admitted for syncope as a low-value practice. Now, what I'm suggesting is that as we discussed, the more appropriate approach would be based on guidelines, really risk stratifying patients to ones that we have high concern for cardiac etiology. And in those patients, please, by all means, get the echo, it's high value. And then you have patients where you have low concern for cardiac etiology. And in that scenario, you can provide reassurance and education to both the learner as well as the patient. But there is this all too familiar nagging question of what if I miss something? I find that one of the hardest parts of practicing medicine is accepting that, in the words of Osler, medicine is a science of uncertainty and an art of probability. So what does the evidence tell us about the probability of missing cardiac syncope by following the risk stratification approach to evaluation? So prior studies have assessed the results of obtaining an echo in the bucket of low concern for cardiac etiology of syncope based on history, exam, and EKG. I'll show you a broad overview of results, with the first column showing the number of patients in this category who had an echo obtained, and the second column showing the number of patients who had an abnormality found on the echo. You can see that in the 3 studies shown here, none of the echoes of low-risk patients found an abnormality. And in the last study, there were 8 patients, or 4%, with an abnormality, but the authors were not able to confirm a causal relationship between the abnormality and the syncope. So in the world of probabilities, I find that the data really supports us in passing on the echo in low-risk patients. So going back to our eager intern here, as the attending, you have the option to use an evidence-based teaching script on when an echo is indicated, or to allow the intern to order a low-value echo for the patient. After all, what are the consequences of ordering a low-value echo? So we often think about the negative consequences of low-value care as unnecessary costs and possible cascades of low-value care. I would argue that in this scenario of a teaching environment, there's also the issue of perpetuating a hidden curriculum in medicine, that we should address our personal discomfort with the inherent uncertainty in practicing medicine by doing more tests. And as hospitalists working in teaching institutions, we're in a privileged position to shape the next generation of physicians. We can serve as role models on ways to stop the cascades of low-value care and teach our learners to become more comfortable with using probability in making value-based decisions. One unnecessary echo in a low-risk patient, just to be sure, may seem unimportant in the moment, but as the role model for our learners, it has much greater implications. And my take-home points here are that all syncope evaluations should include a history, exam, and an EKG, and order an echo only if there is concern for cardiac etiology, and to integrate evidence-based practices to create teaching scripts to mitigate the echo chamber of low-value care. And with that, I'll take any questions.
What a way to finish the competition. Awesome, Neely. Thank you so much.
Thank you.
We have any questions?
Lots of great jobs. Love the last teaching point. Seconds to spare from Monica.
Good.
So judges, all of our competitors finished on time for that question, if you're curious.
Any questions, or we all feel good about not ordering the echoes on low risk?
Man, Preet's just going to poke us all of them.
Guess the cost of the gel would then be the question.
Or our skills in focusing, and if we can trust what we're getting. If the patient's high risk, don't they really owe it to have a truly trained radiologist read it?
Oh, but Dr. Malik is the best.
Oh, well, in that case.
Lots of, just for all the presenters, lots of thank yous and great presentations. Very effective teaching by all of you. Oh, hey, Maha. I clearly didn't look at see who everyone was on here.
Oh, hey.
Okay, I guess if there are
I
any
will
other
commence
questions.
stalling as Monica and Eric work on our scoring. So I really have to start with some just offering of gratitude to everyone involved. So Monica Perkins is the workhorse who makes this whole thing go. I would not be able to do this without her. Just all the reminders and organizing all the things. I can't even say enough about her. Our speakers, of course, all of you worked so hard, and I know most of you had to present this twice, and I know that's not a stress-free endeavor. So thank you so much for that. Our judges, just all of you, thank you so much for your time. I know you're all very busy people. Part of why I know you'd be excellent judges. So thank you so much. Our institution leads, people that I, well, incessantly emailed, Dennis Chang, Taylor Broom, Ryan Buckley, Sahar, Tegvai, and Sonia Dalal. Thank you so much for always responding and always making sure that I had my anxiety assuaged. And the Emory team, Dr. Dan Hunt, who truly, without his enthusiasm and excitement about making something like this happen, I probably would have just watched Netflix and said, so Dan, thank you so much. The Emory Education Council and subcommittee for the competition, always key to making these things happen. And then my VA crew, Eric Bacon, who always helps with the tech side and content selection, that kind of thing. Obviously, Meredith Trubit, the Amy to my Tina, Harka Gorthy, and then I guess this is an old slide set, Caroline Coleman, two people that make sure that my slides aren't terrible when I make these intro slides. So just so many people to thank. I'm so grateful for all of everyone that's on this call. I think we had at peak probably, and I don't know if people are watching together, but just under 60 folks for a first time event. I think that's pretty solid. Just I can't believe this happened, I'll be honest. Okay. Where did that go? All right. So while we wait for scoring, I did want to some fun facts because everyone what you guys don't realize is that both the judges and speakers had to send me the answers to some absurd questions. And of course, the intros, I don't want to take up too much time there, but I thought this was a good time for that. So Lei Du Lin, you know, she's a big fan of was it miniatures? Is that right? Yes. And she has a dollhouse with fancy furniture for her daughter, but she says the fancy furniture is actually for her. And where is this picture? It seems lovely, and you seem very graceful and athletic. Where is this picture?
This is Grand Canyon.
Sweet. I guess I should encourage the judges to submit their scores once they're ready too. That's probably appropriate. As I promised earlier, this is a picture of Alex kayaking. I believe New Zealand. Is that correct, Alex?
Yes, I was in New Zealand.
Okay. You just look like you're nailing it. Was this at the beginning or the end?
I am actually not the most athletic, but I'm glad that I tricked you there in that photo.
Hey man, it's all about making it look good, you know, all for the gram. So it's awesome. And where specifically in New Zealand was this?
Oh my goodness, I'm forgetting the name off the top of my head. When I think about it, I'll let you know.
Okay, just like Voltron, our chief of radiology, Amit Sadani, just best picture. So please explain. Clearly a childhood photo, but what's going on here? How old were you? Where was this?
I think I was 3 or 4 years old, but this was mid-sneeze with a old black and white camera.
That's a skilled photographer.
Yeah.
Because you know you don't have live mode back in the day. You don't have like the one that just does like a bunch back to back. Yeah, this is my favorite picture we got. Awesome. And then Mike was a budding astronaut, from what I recall. So Mike, how old were you in this picture?
I think I was like 6 years old there. But if anyone knows of like an adult space camp, please let me know. I've been looking for one for some time now.
An adult space camp? Yeah, that I feel like, well, there's probably, I mean, if you can pay, I feel like you could probably like go to actual space these days, but that's probably out of our pay grade. Yeah, that's probably out of our pay grade. We're hospitalists. Okay. And then Swarthy, who just got back from the Galapagos. Where is this exactly? I think this looks familiar to me. So where is this?
This was on in San Cristobal Island.
Okay.
There's like a interpretation center there, but there's a little
Yeah.
hike to do around it. But it was cool. I've never seen lava rocks and cacti like in the same exact environment. So it's cool to see.
Yeah, no, the untouched nature, that's a pun, of the Galapagos, I remember just being stunning. When I was leaving, there were like finches, the little Darwin's finches in the airport, just everywhere. I have like pictures of them just sitting on the sofa like that I was next to.
Well, when I was there was we actually like boated or drove up next to a group of wild dolphins, and the guide was like, "Yeah, they usually run away as soon as the boat gets near them, but they're not running away. So quick, get in the water." So we got to swim with wild dolphins, and he was like, "This is a maybe once in a year occurrence where they like don't run away," and they just played with us for 10 minutes. It was really, really cool.
That's awesome. And then is it tortoises? They're freaking huge. Yeah. I just like could not believe how big they were and slow. I mean, when you're
They're
that big,
humongous and so happy. I kind of aspire to be that way.
just living life, man. All right. And then as promised, in the chat, Michelle Brooks, actually her real favorite song is or her theme song would be The Man by Taylor Swift. Off of the fantastic Lover album of Taylor Swift, which was her first away from her original record contract. I know everyone wants those details. Yeah, so still looking for how are we going to stall some more guys? Ran out of pictures.
We're ready.
We're ready? Okie doke. You can when you're ready, you can share the screen. I can unstop sharing mine and you can go nuts. And guys, this is very exciting. First ever winner of the Teaching Invitational. You know, this thing that I've been very excited about. We have a winner. And we have Dr. Nilu Latifi from Johns Hopkins. Congratulations.
Thank you so much. Thank
Oh,
you. This
man.
means a lot, and I really appreciate everybody who organized this. I learned so much from everybody.
Awesome. Man, well, you know,
Thank you.
what can we expect except the winner to be from the home of things we do for no reason. So
I have learned so much about things we do for no reason. I have I care from Lenny, and I felt so like privileged that from the beginning of time I came and I felt starstruck when I saw Lenny on faculty, and I was like, wow, he's the man, he's here.
yeah, it's very exciting. Again, thank you all so much. Congratulations again, Nilu. If you have any thoughts, comments, please send them our way. Hoping that this is something that happens again. I don't know if people are down for it. I know that we would hope to be able to, but you know, schedules, all the life things need to align for those things to happen sometimes. So, but hopefully people enjoying themselves today. We always, both locally and now nationally, like try to make this a fun thing. That's really important to me in particular. We're serious enough at work, so something like this needs to be fun. But if nobody else has any comments, I can give you like 11 minutes back to your day. So I think that's pretty sweet.
I have a comment.
Yeah. Oh, sorry. You know what I forgot to do? Thank you, Michelle. All the judges, please weigh in. Thoughts?
Oh, my thought, I was just going to say, I was just going to check in on my BFF and make sure he was doing okay. You know, he always seems a little bit depressed on his social media. So I just wanted to make sure Paul Williams was doing good.
I mean, at that baseline for sure, but thank you so much for checking. And while I'm unmuted, I just want to again say thanks so much for coordinating and inviting me. It's always, I love this particular theme in general because I think just inertia is such a prevalent problem. It's easy to keep doing the same thing that we've done for forever. So I think people just always critically thinking about things in the service of making sure patients get the right care is such a positive, and then also teaching on top of it. So it combines a lot of things I love. So really great job to everyone who presented and also to everyone who put it together. So thank you again for inviting me.
Awesome. Thanks,
And
Paul.
Nilu, I was going to also ask if you're still starstruck after meeting Lenny.
Even more so. Even more so.
So he hasn't disabused you of that yet.
No, he's just as amazing as he sounds.
Awesome. Eric, do you have any thoughts? Totally fine if you don't.
No, all I can think of is I'm so glad I got into hospital medicine on the ground floor, so I don't have to compete with these amazing lecturers. It was really great. I learned a lot tonight, and thank you for the privilege of being here. It was a lot of fun.
Thanks. Thank you so much. Lei, did you have any thoughts?
Yeah, I really think this is amazing, and thank you so much for doing this. I think the topics presented today are very valuable, and I'm hoping these topics can reach more medical providers so we can make some even bigger difference.
Awesome.
Thank you for having me.
Thank you.
Yeah.
Amit, our resident radiologist.
Yeah, no, thanks for allowing me to be a part of this. My ulterior motive is to rip this off completely for the radiology world. And so this was it was wonderful just learning a lot about the topics, but also about the process and how things work. And this was very enjoyable and fun and educational, and hope to be able to replicate this for my peeps in radiology.
Awesome. I think we have not heard, I think Lisa's the last judge, and then I did want to give Dan Hunt a chance after that. So Lisa, any thoughts?
I will just add my gratitude, appreciation. I learned so much. I want to thank all the presenters, not only for the content, but I can tell how much thought you put into the presentation and the visuals and the, the graphics, and making sure that the points were emphasized visually as well as with the words and the text that you use. So very, very well done. I'm in awe, and I learned a ton. Moni, thanks so much for inviting me and for being a great host.
Thanks, Lisa. And Dan Hunt, thoughts to close us out?
Just want to add my thanks to everybody who's on the call. Terrific presentations. I'm not sure how the judges decided who won. Yeah, a lot of great teaching in a really compact fashion. Yeah, to all the presenters, you now have a national invited presentation to put on your CV, yeah, which is terrific. Yeah, to the judges, thanks so much for being here. Yeah, I hope we'll be able to replicate this in future years. And we may think about a trophy. Moni, what do we think about a trophy? Maybe next year.
And you and the trophies, come on. Okay.
So Moni and Meredith, great work. And Monica, again, really terrific work putting this together. Thanks for being here.
Thank you guys so much. I really appreciate it. And have a good night, guys. And it will not be the Amin Cup, Meredith. No, it will not.